everybody. If you can kindly take your seats so we can stay on time, that would be wonderful. Thank you. My name is Manya Magnus. I'm from the George Washington University School of Public Health. I'm also the CTU leader of the DC Clinical Trials Unit, and I'm a co-investigator with the GW HIV Prevention Trials Network site here in Washington, DC. So I'm delighted to welcome you to DC. I'm also delighted to welcome you to this panel, which will follow the outstanding panel that we just saw regarding developing the prevention toolbox. And now we'll talk about how we're going to use and implement this very important prevention toolbox. So we have a wonderful panel here. I'll begin by introducing our first speaker. Dr. Zubair Luxiamus is a public health specialist and researcher at the Macquarie University, Johns Hopkins University Research Collaboration in Kampala. He is also the protocol chair and principal investigator for the HPTN 111 study. He has served as principal investigator on various studies, including a Fogarty NIH-funded experimental study that assessed the role of community health workers in supporting disclosure among adults living with HIV and heterosexual relationships in rural Uganda. I'm delighted to welcome you.
Okay, thank you very much, Manya. Good morning, everyone. I'm here to take you through our experience in reaching heterosexual men in HPTN 111. Just a snapshot of what we've gone through so far. So what we should take away from our presentation is the fact that HIV prevention and care services inadequately reach men. And the second point is that it's possible to reach men through community safe spaces that are comfortable and convenient for meaningful engagement, such as barbershop. And then the last one, that barbershops and barbers may be leveraged to advance HIV prevention and care services in men. Just to wind a bit and talk about globally on how men are receiving HIV prevention and care services. We know this, that they are lagging behind compared to women globally. And when we look at when we look at East Africa and Southern Africa, where heterosexual transmission is commonest, the figures are the same. When you look at the 95, 95, 95, you need fast track strategy. And when it comes to Uganda, the picture is the same. We have men living with HIV in Uganda who are 3 times less likely to know their HIV status compared to women. And in this country, there are areas with markedly high HIV incidence and prevalence. In this case, we have Kalangala district, which is the most affected. And the HIV prevalence in this area, it's 3 times higher than the national prevalence. And the incidence is 8 times higher than the national prevalence. So the incidence stands at 230 per 100 population, and the prevalence stands at 12%. So what we should also know about Kalangala is the fact that the number of men is 4 times higher than that of women. And from literature, we learned that evidence-based near location and self-controlled HIV prevention and care services are preferred by men. So we know that men are more engaged if models of care are differentiated. So it has been shown that home-based, community-based, and the workplace-based HIV services are preferred by men compared to facility-based. So leveraging this community perspective of the fact that men prefer community-based services, we thought about barbershops. As we see here, that men are comfortably and patiently waiting in the salon to have a haircut. So we know that barbershops are calm and quiet spaces where men have ample time to comfortably learn about HIV services. So from this, we developed a study, which is HPTN 111. It's a feasibility and acceptability study that is assessing barbershop-based HIV prevention initiative among heterosexual men in Kalangala Islands. It's a cluster randomized trial that is abbreviated as TRIM. The primary objective is to assess feasibility and acceptability. The design is a cluster randomized trial, and the intervention is a multi-component one. The first component is Baba shop distributed HIV self-test kits. The second one is status neutral HIV education and counseling. And then the third one is the provision of information for referral to HIV services, still based at the Baba shop. And then the last one is Baba-led peer support education. So the population we are looking at heterosexual men aged at least 16 who are vulnerable to HIV in Kalangala Islands. So this is where the study is located. So Kalangala district is located in the middle of Lake Victoria, which is the second largest freshwater body in the world. And the district has about 83 islands, the biggest being Bugala Island. And to move from Kampala, where the Moju CRS is located, to this place, it's about 180 kilometers, and they need about 6 hours to reach there. So before we started this study, we had to prepare for it, and we had to plan on how to enter the district and also assess the Baba shops. So this is the team that entered Kalangala, which was led by the site leader, Dr. Nakabito. You see, she was excited to have her first move on the waters. So we introduced ourselves to the district and then the district health team, and they granted us permission to have this study done. So we identified the study space, which is Kalangala Hospital, and it is the largest health facility in this area. So after being granted permission into the district, we had to assess Baba shops to ensure that they are available to support this study. We assessed 46 Baba shops in 24 towns for space and willing to participate. And after identifying these shops, we started building rapport with individual Babas. So then we proceeded to community engagement and sensitization. And here we conducted community stakeholder engagement and Baba engagement. What we should know about Kalangala is that 80% of the community is a fishing community. A significant percentage do palm oil plantation, and there is also a significant population of motorcyclists. So these were the key population we were supposed to engage during our meeting, and we exchanged a lot with them, and they told us about the drivers of HIV in their area, which included commercial sex work, due to the fact that men in this area are the ones having money, with women having no money. And then also the fact that the number of men is 4 times higher than that of women, so they always have to compete for the available women. And then also there was mindset change. They told us that some people in this area are no longer scared of getting HIV. So we also engaged Babas separately, and what we found unique about this, that they only know about condoms as the only HIV prevention strategy. It was only one person that mentioned about PrEP and then PEP. However, during our engagement with them, on introducing this project, they saw a lot of opportunities they could acquire from it. The first one, they thought that acquiring knowledge about HIV prevention, and then also gaining respect from the community, contributing to HIV prevention efforts. However, they expected challenges, including lack of trust from the community initially, and then negative attitude from people living with HIV who might be visiting their salons. Then the status of our study, we are recruiting and continuing to learn. We've registered many successes so far. We have witnessed high interest of Babas and men participating in this study. 18 Baba shops have so far recruited, 18 Babas recruited, and 280 men were recruited in 12 weeks. So we've had lessons to learn. We've learned that adequate community engagement and preparation activities are important for successful study implementation and good community reception. We've also learned that interest from Babas and their clients may reflect an unmet need for HIV prevention in this community, and also learned that there is a need to be flexible in study implementation due to the changes in fishing seasons, heavy rains, and tight palm oil plantation schedules. So I want to thank the HPTN 111 team, your great team, you can wave wherever you are. And then I thank you very much.
Thank you so much. We're going to hold questions until the end. I'd like to invite our next speaker, Dr. Jeff Stringer, who is a professor of obstetrics and gynecology at the University of North Carolina School of Medicine, and he's also the director of the Division of Global Women's Health in Chapel Hill, North Carolina. His research focuses on improving birth outcomes for women in low-resource settings. Dr. Stringer lived in Lusaka, Zambia, where he established and led the CIDRs, and in 2012, he returned to Chapel Hill to lead UNC's Division of Global Women's Health. Thank you for joining us.
Thank you so much for the invitation. It's really wonderful to be back here. I haven't been to this meeting in a long time, but just to see my old friends, familiar faces, and meet new friends, and just to see how the agenda is thriving, it's really wonderful. So I'm going to talk about ultrasound. Unfortunately, I have no conflicts of interest to disclose. As a global health person, I've been working my whole career to find a lucrative speakers bureau or something like that, but so far, no dice. Okay, so my group works at the intersection of HIV and birth outcomes. And if there's one thing that we've learned over the years of doing this, it's that without understanding the fetal gestational age, it's very difficult to do this. So this is a slightly complicated graphic showing the sort of relationship of important adverse birth outcomes to gestational age. The green strip across the top of the slide is gestational age going from the preconceptional period all the way through delivery. And you see how these things that we care a lot about are intimately related to GA. So without gestational age, you cannot, for instance, know the difference between a spontaneous abortion or miscarriage and a stillbirth. You cannot diagnose preterm birth or know how severe preterm birth is. You can't diagnose growth restriction or its delivery manifestation, small for gestational age. So it's very, very important. And in fact, without an accurate gestational age, you're left essentially with just stillbirth or fetal loss and this really crude metric that is easy to measure but not particularly useful, which is low birth weight. And the reason that low birth weight is not a good measure is because it conflates multiple pathologic and non-pathologic conditions such as preterm birth, growth restriction, and constitutionally small fetuses, which are not pathology at all. So the point here is that gestational age is extremely important to measuring birth outcomes. Now, some of you may say, well, Jeff, you don't really need ultrasound to do this. You can just use the last menstrual period and then calculate gestational age in that way. So I want to challenge that, that thought through this graphic that you see here, which is a large cohort of women whom we followed from early pregnancy through delivery and measured when they delivered. And we've expressed here on the same graph the rate of preterm birth if you establish gestational age by ultrasound versus if you use the last menstrual period. So these are the same patients. Red line is the LMP and black line is an ultrasound determination of gestational age. And you can see here that the inaccuracy that is associated with the last menstrual period effectively doubles the rate of preterm birth from 11.4% in this case to 20%. Now, it's reasonably easy to measure gestational age with ultrasound. The simplest formula that we have is something called the intergrowth 21st formula. You get a transverse view of the fetal head through the thalamus, thalami. You measure the head circumference or biparietal diameter. And then also another biometric parameter like the femur is measured. These are all put into a commonly available formula that you see on the screen here, and you get the gestational age. Now, of course, in practice, that's not as easy to do as I just said, because essentially we have two big problems. One is that there's not enough sonographers, or not enough ultrasounds. And this particular ultrasound you see right here costs about $100,000 and requires consistent electrical power and so forth. And then obviously there are not enough sonographers. These are very highly trained people who have a intimate understanding of fetal anatomy and maternal anatomy and how to navigate the probe to exactly the right place to get the relevant views. So luckily there have been a couple of advances in technology that may help us to jump over a couple of these obstacles. So with respect to not enough ultrasounds, you no longer really need a $100,000 GE Voluson machine like I showed in the previous picture. There's been a profusion of these small battery-powered ultrasound devices available over the last 5 to 10 years, which you hook them up to your cell phone or to your tablet computer, and they can be had for as low as $1,000 for some of the Chinese manufacturers to up to $6,000 or $7,000 for some of the other ones. And we've worked quite a lot with the butterfly probe, which you see in the top right here, which is about $2,000. So these are much cheaper than they used to be. And the solution for not enough sonographers comes in this form, which is it turns out that you don't necessarily have to have an expert sonographer who's navigating that ultrasound probe to exactly where you want them to go. So you can implement a protocol, what we call blind sweeps, where the sonographer, an untrained person or a novice person, can just collect, sort of mow the lawn with the ultrasound probe and collect ultrasound videos that cover the entire maternal abdomen and uterine contents. And then those videos can be put into a computer vision model or a deep learning model that can make diagnoses. And it turns out that this works extremely well. So this is a paper that we published a couple of years ago, and I have permission from Dr. Cottrell here to say that she was a participant in this study, showing that using this technique that I was describing, we can estimate gestational age as accurately with that technology as a standard sonographer using a $100,000 machine. It's really quite remarkable. And this has been subsequently, in the last year or so, validated in a prospective study that we'll be publishing next month. Other diagnoses are also possible. So here is the performance of the same sort of approach to diagnosing twins and malpresentation. But importantly, for birth outcomes, fetal weight, we're really accurate at assessing fetal weight through this particular technique. In fact, better than most of the established formulas that are used, and whether you're trying to get just a number or to classify a fetus as less than 2,000 grams, which would probably need referral to the NICU, or a macrosomic fetus greater than 4,000. So I just want to show you a quick video here of how this works. Hopefully this is going to work. Yes, so this is a 5 of the models that we've worked up so far have been incorporated into this software, and you see here a novice, so-called novice sonographer, or someone who's she's actually not even a clinician. She has a bachelor's degree, and she's a research assistant in our clinic, who is doing the operating here. So she measures the symphysis fundal height. She types that into the tablet, and then the tablet, the software, sets the depth and the gain setting on the ultrasound probe and tells her how many sweeps she needs to do. So you see now she's getting 5 in this up and down or craniocaudal orientation, and we'll speed it up here so it doesn't take too long to do. But you see that there's no real ultrasound images that are coming back to her. She's only being guided in this way by the software. So she'll do 5 up and down, and then she'll do 4 across like this. And ultimately, as the sweeps are being done and so forth, the AI models are ingesting these videos and doing their calculations and so forth. So by the time she gets to the end of it, we have the gestational age, the calculated due date, the fetal weight, a measure of the amniotic fluid, the presentation, which in this case is cephalic, and we know that this is a singleton gestation. So my research coordinator at my site really wanted me to add this part to the video just to show that we happen to know in this particular case that this patient was 35 weeks and 6 days because she had had a very early scan done previously in pregnancy. And you'll see here that the app, which is the column on the right, is actually 1 week more accurate than an expert using a regular ultrasound. So I have 1 minute left, and luckily, I think that's all I have to say. So I've got a key takeaway slide, as was asked of us. So here's what I'd like for you to know. First of all, accurate assessment of gestational age is required for birth outcomes research, and I feel very strongly that that's the case. Low-cost ultrasound probes, with or without AI, will allow the accurate gestational age measurement pretty much anywhere. And then from that, almost any site, including yours, can now incorporate ultrasound into its research with pregnant people. So if any of you from your sites have interest in this, please contact me. I can't buy the ultrasounds for you, but you can have the software and you can have the app and so forth to incorporate this into your HIV prevention and birth outcomes research. And that's it. We're funded by the Gates Foundation. I'd like to really have to thank all the research participants in Lusaka and Chapel Hill, including Mackenzie here, for helping us with this work. Thank you so much.
Thank you so much. I'm so happy to see AI in a favorable context right now. So it's lovely. Great. Thank you. We'll think of all your questions for a little bit later. I'm delighted to introduce our next speaker. Dr. Romain Sioul is a mathematical modeler, biostatistician at the HPTN Modeling Center, and he's a research fellow at the Imperial College School of Public Health in London. His research aims to improve our understanding of HIV transmission and control in low and middle income countries using modern mathematical and statistical methods in collaboration with global and local institutions. Thank you.
Thank you. So good morning, everyone. So as you heard, I'm a mathematical modeler. So a part of my job is to estimate the potential impact of interventions, but also to understand how the risk of HIV or new HIV infections are distributed across different population subgroups which are vulnerable to due to their prevention and treatment needs. So for example, young women or female sex workers. So one very important problem in our field is that there are different indicators which can measure the contribution of these vulnerable populations to new infections. And during this talk, I'm going to try to convince you that the most common indicator, which is the fraction of all new infections acquired, is insufficient to identify the most important population subgroups when we design a prevention intervention. And so based on the work we've done, we have recommended UNAIDS and other modeling teams to also use indicators which measure the long-term effects of preventing transmission from different subgroups. So I think everyone in the room can agree with me that the HIV prevention programs can be improved by better understanding the contribution of vulnerable population subgroups to new infections due to their prevention and treatment gaps. But in the literature, the estimates of the importance of these subgroups can vary a lot across settings, studies, and also partly due to the indicator that he used to measure this contribution. And the indicator which is by far the most used is the fraction of all new infections which are acquired in 1 year by each subgroup, and we've seen it yesterday during one presentation. It's reported every year by UNAIDS for each global region, and it's highly cited, as we've seen already yesterday. But the problem with this indicator is that it is known for underestimating the contribution of key populations and the importance of addressing their needs in order to reduce all new infections. So we conducted a model comparison study where we evaluated the contribution of different population subgroups to new infections, but using different indicators with the purpose of making recommendations to UNAIDS and other modeling teams. So this particular project was a part of a wider project about the modeling of key populations, and here I just wanted to acknowledge my collaborators on the project. So for our study, we first identified 4 common indicators in the literature, and we elicited feedback on these 4 indicators to our collaborators, and then invited modeling teams that had an HIV model calibrated to a sub-Saharan African setting to provide estimates for each indicator in a standard spreadsheet for 7 population subgroups, which I will describe in the next slide. And we also asked some questions about their model, the assumptions, and the epidemic context. The first question we asked ourselves was whether all the HIV indicators will identify the same most important subgroup, but also what will be the magnitude of the difference between the different HIV indicators for the same model and subgroup. So the population subgroup that we have investigated for this particular study were 7 groups, key population and non-key populations, so female sex workers, their clients, gay, bisexual and other men who have sex with men, as well as younger and older non-key population women and men. And as you can see, some of these populations are relevant for HPTN studies, actually. So the first indicator that we looked at was the acquisition indicator, and it is the fraction of all new infections in 2020 which were acquired by a specific subgroup. And as I told you earlier, this is by far the most used indicator. His mirror image, say, is the direct transmission indicator, which is the fraction of all new infections in 2020 which were directly transmitted by a specific subgroup to their partners. The third indicator is the 1 year, what we call the 1 year TPAF, which is the fraction of new infections directly or indirectly transmitted by a specific subgroup over 2020. And this is calculated by calculating the number of, the proportion of new infections that will be averted if this population could not transmit HIV during a period. So the idea behind this indicator is that when we block all transmission from a subgroup, we'll not only avert direct transmissions, but also we might avert some future transmissions from their partners to their other partners, so from the transmission to their partners' partners. And lastly, the 10-year TPAF is the same as the 1 year TPAF, but calculated over a long time period. So here it will be for 2020, 2029. Okay, thank you. So which allows us to take into account a larger number of indirect infections and better predict the long-term impact of an intervention. So we collected estimates from 15 different mathematical models, 10 in Eastern and Southern Africa and 5 in Western and Central Africa. And 10 out of these 15 models provided estimates for each subgroup. So the first question was whether all the indicators will identify the same most important subgroup, and we looked at this question for the different regions separately. So here what I'm showing you is the number of models identifying a specific subgroup as the greater contributor. So at the top, we can see that pretty much all models, so 5 out of the 6 models, identified older non-key population women as the one contributing the most to new infections, and was mostly due to their large size, with only one model identifying older non-key population men as acquiring the most. Okay? But when we looked at the other indicators, older non-key population men actually were often predicted as the largest contributor. So here it makes sense, because if we say that in these countries women acquire most infections, it means that men transmit most infections. And as you can see here, what different indicators can identify different subgroups to intervene on. In Western and Central Africa, we found a similar result, where older non-key population women were also identified in almost all models as the largest contributor when using the acquisition indicator. But when using the other indicators, clients of female sex workers, MSM, and older non-key population men were often estimated as being the largest contributor. So here you can see that if we had only focused on the acquisition indicator, then we would have neglected the contribution of key populations and male key populations in particular. So the second question was how different can the indicators be for the same model and subgroup? And what I'm showing here is the scatter plot where on the x-axis, on the y-axis, sorry, it's a direct transmission indicator, and on the x-axis, the acquisition indicator. And the diagonal line means that the two indicators identify the same population. And one symbol corresponds to one model estimate. So what we saw here is that, as you can see on the top left, probably here, so all the symbols are below the diagonal line, which means that all the models agreed that younger non-key population women directly transmitted less infections than they acquired, so up to threefold. And we found a similar effect for older non-key population women, but to a lesser extent. And on the contrary, older non-key population men and clients of sex workers always transmitted more infections than they acquired, so up to threefold. And we found largest differences in Western and Central Africa. So here it means that only using the acquisition indicator could largely underestimate the potential impacts of preventing transmissions from male and male populations, male key populations in particular. Thank you. So here I'm showing the 10-year T-path against the direct transmission indicator, and our results show that, among young non-key population women and clients of sex workers, intervening into this population might have a larger impact on the overall HIV incidence because you avert more infections indirectly. So there will be like an additional long-term benefit of addressing the needs of these populations. So to conclude, we found substantial differences between the different indicators used to quantify the contribution of these subgroups which inform HIV prevention programs, and the differences were largest in Western and Central Africa. The acquisition indicators did not reflect the potential impact of preventing transmission from male population in the countries. They have higher transmission risk, larger treatment gaps, etc. And we recommended UNAIDS and future modeling studies to systematically estimate and report these long-term indicators, such as the T-path, to better give us an idea of what would be the impact of reducing transmission from these groups. Thank you very much.
Thank you so much. And last but not least, I'm delighted to introduce Dr. Mackenzie Cottrell, who is an associate professor and clinical pharmacologist in the Division of Pharmacotherapy and Experimental Therapeutics at the University of North Carolina in Chapel Hill, UNC, Eshelman School of Pharmacy. Her research interests focus on applying novel clinical pharmacology modeling methodologies to optimize antiretroviral doses for specific end-user populations and advance HIV prevention, treatment, and cure strategies. She is also the co-director of the Clinical Pharmacology and Analytical Chemistry Core of the UNC CFAR. Dr. Cottrell.
Thank you for that introduction. And thank you to the conference organizers for allowing me to speak on this topic. I'm going to start with some key takeaways, but I should say, while I didn't put it on the slide, I have no conflicts of interest to disclose. Since it's not written down, you'll just have to take my word for it. So the key takeaways for this talk are that women need more PrEP options, and they could greatly benefit from on-demand PrEP options. PrEP pharmacology differences between vaginal and rectal HIV transmission sites may necessitate a specific on-demand PrEP option tailored for vaginal transmission. And modeling and simulation can be used to that end to inform on the optimal on-demand dosing schedule and potentially harness pharmacology, well-designed pharmacology studies to support that dosing recommendation instead of randomized controlled trials. So on this slide, I'm outlining the current PrEP guidelines for rectal versus female genital tract transmission. And as you can see in the panel on the left, which discloses rectal transmission, there are some important differences with regards to oral PrEP options. So the Discover trial proved the combination of emtricitabine with the prodrug, the alafenamide prodrug for tenofovir, when used daily for preventing rectal transmission. And the IPRGAY trial was used to approve emtricitabine with the original disoproxyl fumarate prodrug of tenofovir when used on an on-demand schedule of 2 tablets before sex and then 2 tablets daily for 2 days after sex, also for rectal transmission. But because these trials were conducted exclusively in male and trans feminine populations, their results could not be extrapolated for vaginal transmission, leaving women only with the long-acting injectable or emtricitabine and TDF daily for PrEP. So this is the only pharmacology slide that I'm going to show. I know it's complex, but I hope to use this to set the stage for why results from male and trans feminine populations can't be readily extrapolated over to vaginal transmission. Along the top line of this slide, you can see how these 3 prodrugs that we've discussed are activated by host enzyme systems to enter the cell and then be transformed into their ultimately active triphosphorylated form. Along the bottom of the slide, you can see the pharmacodynamics, where these triphosphorylated compounds then compete against host endogenous nucleotide pools for incorporation by reverse transcriptase into the proviral DNA strand. This incorporation effectively impedes growth of the DNA strand, blocking infection. And given the fact that the entrance and transformation of these prodrugs requires cellular enzyme systems, you may imagine that the concentrations of these molecules may differ throughout the body. And this was first shown in a landmark pharmacology study in 2011, where healthy male and female volunteers taking emtricitabine with TDF donated tissue from the female genital tract and rectal tissue, and concentrations were interrogated. The results of this study are shown in the graph on the left, where the tissue to blood plasma ratios are plotted on the y-axis, and you can see that there's a 100-fold increase in ratios observed in the male rectal tissue when compared to the female genital tract tissue, denoted by the black bars for the tenofovir prodrug. This finding was confirmed in a follow-up pharmacology study, and the results of that follow-up study are shown with the average exposure of these active PrEP metabolites on the y-axis for each step of the molecular pathway on the x-axis. And again, we found in this study that tenofovir diphosphate exposure in the rectal tissue was about 10-fold higher, and the rectal tissue is shown in red here, when compared to the female genital tract tissue. Interestingly, this follow-up study found that emtricitabine triphosphate concentrations were about 100 times higher in the female genital tract when compared to the rectal tissue. So given these pharmacologic differences between HIV transmission sites, Anderson et al. Sought to explore whether these differences result in things that we care about, outcomes level data in PrEP effectiveness. What I mean by effectiveness is the ability of PrEP to prevent infection given real world less than perfect use. And for this, Anderson conducted a post hoc analysis of HPTN 083 and 084 data. And the results of this analysis are shown in the graph on the left, with the y-axis indicating risk reduction, where it's flipped, and 0% risk reduction is at the top of the axis, and over 99% risk reduction at the bottom. And you can see that when they explored a biometric adherence estimate, and that allowed them to group participants according to the number of doses that they were taking, that rectal transmission risk reduction is much greater at an adherence level of 2 to 3 doses per week, that's shown in blue, when compared to vaginal transmission risk reduction shown in black. In another post hoc analysis of 11 post-market PrEP demonstration trials, Marazzo et al. Found that across around 3,000 participants who provided adherence data, excuse me. They found that while HIV incidence rate was relatively low amongst those women reporting 4 to 6 doses per week, it wasn't perfect when compared to 7 doses per week. And so we have shown through modeling and simulation that we can recapitulate well these clinical trial results. And in the modeling and simulation study that I'm reporting on this slide, we used a population pharmacokinetic model that considered exposure at the transmission tissue level and paired that with a lab-based benchmark for efficacy. And you can see, akin to the Anderson findings, that with just 2 to 3 doses per week, rectal transmission has a higher risk reduction when compared to female genital tract tissue. Yet, akin to the Marazzo study, with 4 to 6 doses per week, while not perfect, the risk reduction for female genital tract tissue is high. And I should have told you on this slide that on the y-axis, we're reporting a % of a simulated population that met our efficacy target. And on the x-axis here, we're reporting the simulations when the simulated population is taking 1 to 7 doses per week. So given the concordance between clinical trial results or analyses and this modeling and simulation, it stands that we could use modeling and simulation to optimize an on-demand dosing regimen for vaginal transmission specifically. And here we've used the model that I just described to do that. Again, on the y-axis of these graphs, I'm plotting the % of the population that is above our efficacy target. And here on the x-axis, I'm plotting the days after sex. In the graph on the left, we're plotting these results within different compartments for the traditional 2-1-1 on-demand dosing regimen. And the red line indicates rectal tissue. The purple line is white blood cells within the blood, and the blue line is female genital tract tissue. You can see that the female genital tract tissue quickly falls to less than 50% of the simulated population being above target by 7 days after sex. And while it's not quite certain how long you have to maintain effective PrEP exposure after a sexual event to abort infection, early animal studies indicate that 7 days may be a good target. So that's what I'm looking at here. We can then modulate the on-demand dosing schedule and simulate female genital tract exposure. And that's what I've done in the graph on the right. Again, this is % of the population above the target. These are all female genital tract simulations for different on-demand dosing schedules of 2-1-1 as the solid line, a 2-2-1 as the long dashed line, and a 2-2-2 as the short dashed line. And you can see that the 2-2-2 on-demand dosing schedule would improve the % of the population meeting the target by about 30% and could be an optimal dosing schedule to explore in subsequent studies. So that brings me back to my key takeaways. Just to recall, on-demand PrEP dosing for women could improve PrEP access for women. Pharmacologic differences in HIV transmission sites may mean that we need to tailor the on-demand dosing schedule for vaginal transmission, and modeling and simulation can be used to that end. Thank you.
Well, first of all, thanks. Let's give another round of applause for our speakers. That was just terrific. It's very exciting to see how new technologies are coming into our prevention world. Dr. Beyer.
Yeah, is it? Oh, okay. Well, thank you. Chris Beyer from Duke University, and HPTN 096. This actually is a question or comment for Roman. Thank you for that modeling presentation. I think that's very helpful and informative, and it's a novel approach. The question I have for you is when you have the finding that so much transmission is coming from essentially reproductive age men who are not members of key populations, that makes perfect sense given the way the epidemic works and the high numbers in women, but it also suggests a denominator that's huge. Right? That's essentially all reproductive men of that age, and so that is very challenging from a prevention perspective. How do you reach and get? You can't put all of Africa on PrEP, and in contrast, of course, the MSM numbers, as we all know, the incidence is much higher, but the denominator is very small. So maybe you could comment on that. I think it's compelling to think that that we really need to be thinking so much more about men. It's nice, actually, that you came right after the barbershop presentation, but it does mean we'd have a very different prevention approach, and maybe it really speaks to why we still need a vaccine.
Thanks so much. I'm also just going to ask that we can squeeze in as many questions as possible so we keep the questions and answers as brief as possible. Thank you.
So the denominator is high, as you say. I think when thinking about an intervention, obviously you consider the number of transmission from a group, but also like the efficiency of your intervention in terms of the acquisition rate or transmission rate. And I think what my talk wanted to tease out a little bit is that probably some interventions block transmission, for example, test and treat. Some other PrEP will only focus on acquisition. Some do both, like with condoms. So I think it's more about what I want to show is more about thinking about the right intervention for the right population. And my presentation, for example, highlighted Western Africa and Central Africa, a place where there's like a huge difference between transmission and acquisition. This, to me, could be due, for example, to the high prevalence of circumcision, which already decreases the acquisition risk of male by a large amount. So I think it's also about which intervention and which population.
Thank you so much. Dr. Cohen.
Thank you. Let me just make one comment. First, thanks to all the speakers. Those are really interesting presentations. Makes the meeting wonderful. TDF-FTC is not going to go away, but there is TAF-FTC. So this is for Mackenzie. Do you have any, and Gilead and Jim Rooney's here is moving forward as fast as they can with TAF-FTC for women in their purpose one of their purpose studies. Do you have any sense of the modeling sense of TAF-FTC or not? And it's an unfair question, really, because you can talk about it. And Mark has the same question. His would be worded better. He asked your question.
Good. Do I have to turn this on, or is it on?
I think it's on.
It is on. Okay, great. Well, I'll try to keep it brief. So we have models that can demonstrate the distribution of TAF in blood. But to date, we have not seen any pharmacokinetic studies come out that provide really rigorous pharmacokinetic data within the tissues for TAF. There was a study conducted that's been published. It came out of Conrad. And the issue with that study is that it's quite hard to see these active metabolites in tissues, and we didn't get down quite low enough to really see it well. So a large proportion of that data set was below limits of quantification, and it didn't lend itself to modeling. To date, there's been a single-dose study that suggests maybe it's lower in female genital tract tissue, but I wouldn't put too much stock in that because it was a single-dose study. And I would love to see another pharmacokinetic study with TAF that we could model.
You'll be doing it.
Oh, good. Let's do.
Yeah, so maybe just a quick follow-up question since we're on the pharmacology topic and to Mackenzie. So, you had showed in some of the previous work that FTC triphosphate concentrations in the female genital tract were significantly higher than tenofovir diphosphate. And when we think about, adherence markers and efficacy, a lot of the focus is on tenofovir diphosphate. So in your models, when you were looking at your efficacy thresholds, was that based on tenofovir diphosphate, emtricitabine triphosphate, or both?
Both. It's the lab marker is a synergy model that explores both together and their synergistic interaction. And so we feed each individual concentration that we model in the tissues into this synergy model and come up with a specific percent of maximal inhibition for the various concentration
And can you
profiles.
comment on the relative half-lives of both of those in tissue?
Yeah, I would love to. It appears as though emtricitabine triphosphate has a much shorter half-life within tissue, and I believe that in the female genital tract, emtricitabine triphosphate is what is driving efficacy, which is why you see in the intermittent dosing simulation the proportion of the population above the target drop off so quickly. It's because emtricitabine is the powerhouse in the female genital tract, and it does not sustain concentrations as long as tenofovir does, which tenofovir is the powerhouse in the rectal tissue. So,
Great, thank you.
Thanks so much. I can't see that far, but you over there.
Hi, Audrey Pettifor, UNC. Thanks, Mackenzie. That was great, and I feel like this is really an important space to be thinking about. I mean, for people who are not taking their PrEP every day, but I feel like anecdotally we hear from a lot of our sites that women are probably taking PrEP in some kind of on-demand way, probably not because there's no clear guidance. It's unclear how they're doing that. So I guess one is like, I guess I'm curious if folks in the room are collecting data on how women are taking this, because I wonder if some of that empirical data can help with some of our modeling and thinking about how women are, some observational data to kind of get at that. But then I guess I'm curious if you could have a trial, what you would like to see as like a next step moving beyond the models.
Oh my. So I don't know that I can answer what women are using currently. There was a paper put out a few years ago that explored across PrEP users what are the typical patterns of use, and it sounds like there were some schedules out like dose on the T's, Tuesdays and Thursdays, and various forms. But I don't know that I've seen that specifically for women, and I don't know that I've seen that in the context of an on-demand dosing schedule. In terms of a study, if I could design anything, I think that I would really like to see a couple of the dosing scenarios that we've simulated, dosed in vivo, collect some pharmacology data to confirm the results of the simulations, and maybe just call it good at that. I don't know. I'm not being very creative. I think I maybe need clinical trialists to help me with the rest of this.
That's what's so great about this
that's where I'll land.
collaboration is there's so many, so generative, so that's great. I think we have time. Thank you so much. I think it's such an important question, so I think that this gives fodder for future thought. I think, Dr. Vermund, we have time for one more question.
Stan Vermund, Yale School of Public Health. Dr. Luke Yazumi, I wonder if you could comment on the representativeness of the men coming to barber shops. I'm sort of thinking to myself, if I'm comparatively rich, maybe somebody comes to my house, and if I'm a poor farmer eking out a living, I don't really have time to go into the little town and get my hair cut. I just cut it myself. Or what sense do you have of how representative these folks coming into the barber shops are of the general male population at theoretical risk?
Thank you, Dr. Stan. What we have in Uganda and Africa tried that men usually use barber shops. They always want to have their hair short, and they always want to look smart. So whether someone is rich or middle or lower class, they always go to barber shops. And in the shops we've recruited so far, we have a representation of those shops from towns of well-off people, and then also representative from those low-lying areas. Yeah, so we think we have a good representation for all men. Thank you.
Thank you. Great question. Well, we are perfectly on time. One more round of applause for our speakers. And I think we are now ready for lunch. Is that correct? Yes, great. Enjoy your lunch. Thank you all so much.